It's my pleasure today to start the first session, the first lecture, with Dr. Hallström Westes. She's a professor of perinatal. Excuse me. Yeah. She's professor of perinatal medicine, Department of Women's Children Health, University Hospital, Sweden. So, welcome, Dr.
Thank you very much. Good morning, everybody. I'm just trying to organize myself here a bit. Check. First, I would like to thank the organizers for the kind invitation to come here. It's the first time I'm in Saudi Arabia, and I have had a very, very pleasure. Will have very, very pleasure memories from the visit here. I'm going to talk about promoting development of the preterm brain. First, I would like to a little more introduce where I come from. I come from Sweden. I come from this Uppsala, which is just north of Stockholm. Sweden is like Saudi Arabia, a kingdom. We have a king. But he has no power. We have our parliament. And here below you can see some famous things from Sweden. Zlatan Ibrahimovic is probably the most well-known football player. We're doing Volvo cars and from Chinese owners. And this is our dream of summer. You can see the red small houses and the flags. The university I belong to is one of the oldest in the Northern Europe, and we have some famous people. One is Professor Carl Linnaeus, famous botanist who classified plants, animals, and minerals. And the other one is Professor Anders Celsius, who was an astronomist and who created the Celsius temperature scale. I have one disclosure, and that is that I'm a medical co-director at the Karolinska NIDCAP Training and Research Center. The outline of my talk will be, I will talk about exposure to pain and stress in the NICU and the long and short-term effects of this and how we can treat pain. And I will also talk a bit about developmental care and family-centered care. Promoting development of the preterm brain includes several aspects which I will not mention today, but not least the obstetric, antenatal, and intrapartum care is important for the baby's outcome. And we know that antenatal steroids, magnesium sulfate, mode of delivery, and experience and expertise do count when it comes to the infant's future. We also know that immediate neonatal care has major impact on the baby's outcome, and that also the first ventilation, how we manage circulation, is dependent on the experience and expertise and will affect outcome, as will nutrition, pain and stress, how we treat the baby during the months of care they spend in the NICU, and also that we do follow-up after discharge for early detection and intervention of neurodevelopmental problems. So this infant, born at 24 gestational weeks, we know this infant will be exposed to multiple painful and potentially stressful procedures, risk of suboptimal nutrition, noise, smell, separation from parents, and all associated with poorer development. These are two famous studies showing the very, very large exposures of painful and distressing procedures these babies are exposed to. The left slide here is from Barker and Rutter. It's an old slide from the 1990s showing that the most immature babies could have up to several hundred painful procedures during their NICU stays. The other one is a French study also showing the number of painful and stressful procedures also showing over the first two weeks only, showing that the smallest babies may suffer up to 150, 200, sometimes 300 pain and stressful procedures. And we know that this will create responses in the baby. The acute responses that we can see is increased heart rate, increased or decreased apnea, respiration, increased blood pressure, often decreased oxygen saturation. Motor activity can either increase or decrease, as well as crying and facial expression may also vary. But what we also can see is that these exposures are associated with increased cortisol and also with increased brain activity, which you can measure with EEG, evoked potentials, but also increased cerebral blood flow, measured with NIRS and functional MRI. But we also see that in the long run, this is associated with poorer brain development. And this is what I'm going to talk about. Almost 15 years ago, there were 2 studies coming out that studied brain activity with NIRS in relation to pain responses. And they could see that pain elicited changes in cerebral blood flow in the preterm babies. This is one of the studies that came from London. The other one came from Sweden and America. And we could see that only tactile stimulation did not make any major differences, but a venipuncture elicited large responses. These were these studies were very much discussed, and because everyone could see that this is acute responses that are maybe not very good for the baby. And then there come another study from Dr. Limperopoulos, an American study, also looking at with NIRS on cerebral hemodynamic changes during intensive care procedures during the first days of life in extremely preterm infants. And she studied some, made just the normal procedures, diaper change, and the tracheal tube repositioning, and the tracheal suctioning, minimal manipulation, and complex events. And what you can see here on the second column here is the change in mean arterial blood pressure. It was significant for all these procedures. It increased. What you also could see was that there were major changes also in the total hemoglobin levels in the brain, indicating increased blood flow to the brain associated with these procedures. And especially one thing which could be seen was that diaper changes, if you lift the legs above the head, gave rise to a major response in blood volume increase. So we could see this, and we asked ourselves, is a nappy change stressful to neonates? And we made a study together with Eva Morelius, a Swedish nurse, and we looked we created a standardized nappy change. And we did this the first week of life and then the second week of life. And we had a baseline, and these are extremely preterm children in the NICU. These are more mature babies, and these are healthy term babies. And you can see here that in these children, you have in the healthy term babies, you have a slight rise in cortisol due to the nappy change. But the extremely preterm babies, they are already very, very stressed, and they cannot manage a stress response, so they decrease their cortisol level. And a similar pattern was seen during the second week of life, where they still had higher cortisol levels, but that this decreased after the nappy change, while the sick, more mature babies were more stable, and the healthy term babies had lower levels but increased slightly as a normal response to the nappy change. And I'm just showing the different patterns, what we could see. This is PIP scores, pain scores, is what that the very immature babies, they were affected much longer than the more mature babies and the term controls. Somewhat later, this neonatal infant stressor scale was created, and I think it's a very interesting scale. You can see it contains multiple variables, and you assess the stress level of the infant when you do this, and it's different depending on the maturity. But what you also do is that you actually reflect and measure your own stress level for the procedure. So you can. I think this is a very good scale, because you have to think do I believe that this is stressful for the baby? This stress scale was used to measure stress in 65 very preterm children with below 30 weeks during the first weeks of life. And this was also a major publication that made news, because this is Terry Inder's group. She could show that the NIST score, the total score of this stressor scale, was directly correlated with the brain growth. So these babies who were exposed to multiple stressful procedures had poorer brain growth, they had smaller heads at term. And they also had poorer connectivity between the temporal lobes, the ones who had high stress. This study has been followed by several others, and I'm summarizing them here. They have mainly been done in Vancouver by a group from Ruth Grunau and Stephen Miller when he was there. He's now in Toronto. And what you can see is that these are multiple study. Bromelte came as the second paper, to my knowledge, also including a large number of very preterm children. They did MRI at 32 weeks and 40 weeks postmenstrual age, and they noted that the greater neonatal procedural pain was associated with reduced white matter and reduced subcortical gray matter maturation. Another study looked at a similar group of children, but looked at them with MRI when they were almost 8 years old. And they could see that the babies who were exposed to more pain-related stress had thinner cortex in 1/3 of the cerebral regions that they measured, predominantly in the frontal and parietal lobes. Another study from the same center also looked at school-aged children, and they looked with magnetoencephalography, a very advanced type of brain function and measurement, which is not available everywhere. But they could also see that the babies, extremely low gestational age infants who were exposed to more pain-related stress procedures had poorer functional brain activity, but also poorer visual perceptual abilities when they looked at theory, visual motor integration, and WISC, standardized IQ test. So this is really worrying, and the studies continue to come. And I think this is also a very interesting study that came out just 2 years ago, because this is also from the same center. What they could see, and what you can see on the graphs down here, is that they looked at the burden of early which is within the first 1 to 2 weeks, and late, which is after that, skin breaks. And they could see that it was mainly the early skin breaks that correlated with poorer thalamic growth, poorer white matter organization, but also with 3-year cognitive and motor outcomes in the preterm infants. So what can we do about this? Can we prevent our babies to be exposed to pain and stress? Well, we can think about how we can reduce pain and stress, and really, before we do anything, try to ask ourselves, is this necessary? And if we have to do something, what can we do then? Well, there are different modes. We can use pharmacological managements. Sweet solutions is very popular. Paracetamol, opioids are sometimes used, but less nowadays. And we can also use non-pharmacological management, skin-to-skin care, positioning, swaddling, holding, facilitated tucking, and breastfeeding, breast milk, and non-nutritive sucking on pacifier, for example. So what do we know of the effects of pharmacological pain treatment? And I have only listed recent Cochrane reports and meta-analysis on this slide. Just to very briefly go through, we know that sucrose is effective for reducing procedural pain. You can see this was studied in 7,000 infants and 74 studies, so I think this is quite stable data. Glucose have analgesic effects, which also can be used for procedural pain reduction, and I think this is also established. As is the effect of paracetamol, which cannot be used to reduce procedural pain, but may reduce need for morphine, for example, following major surgery. Local anesthetics like EMLA have effects of uncertain clinical significance, but these are 8 small studies. And there is no indications for routine use of opioids, and I will come back to that in a second. So does these measurements help us to improve the development? These medications help us to improve the outcomes of babies? Well, we really don't know, but this study, which is also quite recent, tells us that glucose administration does not mitigate the pain-associated negative structural and functional brain development. So it may not help us, it may only calm the infant, but still have the negative effects on the brain. Sorry. I'm jumping in the wrong direction, sorry. So what can we say about long-term neurodevelopmental outcome after neonatal morphine? Well, there are conflicting results. Some say that it's not good, and some say that it doesn't matter really. So at the moment, it's a big question mark about the effects of long-term effects of morphine. Well, then what do we know about non-pharmacological pain treatment? And again, I summarized mainly Cochrane analysis here. We know that skin-to-skin care appears to reduce pain responses. We know that other intervention also seem to decrease pain responses like non-nutritive sucking, swaddling, facilitated tucking, rocking, and holding. And this has been established in thousands of infants. And if available, breastfeeding or breast milk could be used also. This leads us into developmental care practices, because all these measures are, again, sorry for doing the wrong. All these measures can be included in what we call developmental care practices, which include struggles to limit, reduce pain and stress, and increase the comfort of the baby. It also includes light and noise reduction, promotion of sleep, and family-centered care to support parents as primary caregivers, to advocate no separation between mother and child, to advocate for skin-to-skin care, breastfeeding, family support, and home care whenever possible. We know that babies are not only exposed to a lot of painful procedures, but we also interrupt them during, for example, sleep. And this is amplitude integrated EEG recordings from 2 babies, and I'm just showing you, I will talk more about that later. This is about 3 hours of recordings. This is quiet sleep periods, the broad bands here. This is the baby at 32 weeks, and this is the baby at 36 weeks. This is quiet sleep, quiet sleep, quiet sleep, quiet sleep. And here you can see it was interrupted. Mainly this was a diaper change. The baby was woken up. And you can see the baby does not come back to sleep again. The baby is awake in here. At 36 weeks, this baby was more stable, and this was also a diaper change, and managed to go back to quiet sleep again after this procedure. Given the number of diaper changes that are performed each day in each baby in the NICUs, I believe that if we counted this kind of interruptions to sleep, it would also be similar to the Barker and Rutter and Carvajal studies on painful procedures. And we don't know the effects we have on future sleep and development in these children. Kangaroo mother care also have some established benefits, as presented in Cochrane reports. In the healthy newborns, it can benefit breastfeeding, cardiorespiratory stability, and less crying. And in the low birth weight infants, it's been shown to be associated with lower mortality, less nosocomial infections, less hypothermia, and a shorter stay in the hospital. NIDCAP is one of the techniques that has been used a lot and been discussed a lot. What we know is that NIDCAP results in shorter hospital stay and higher mental developmental and psychomotor developmental index at 9 months. But there is a lack of long-term studies showing that NIDCAP is beneficial in the long run. So have been associated with EEG and MRI, better function on EEG and MRI in 2 small studies, one in preterms and one in infants with intrauterine growth restriction. What has also been shown is in the randomized study was that family-centered care, where the babies stay together with their parents in the NICU, resulted in shorter hospital stay, but also with less bronchopulmonary dysplasia. And I think this was especially interesting because some of the NIDCAP studies have also shown not the long-term effects that we expected on development, but less BPD for some reason. And that was also shown in the Edmonton NIDCAP trial, showing a shorter hospital stay again, and less BPD in the babies. So what can we more do for the babies? Yeah, we can think when we're doing these, expose the babies to various care procedures, we can just consider how we do this. And this is from France, showing that if we do a procedure where we actually try to, as much as possible, to reduce pain and stress, we can decrease the responses in the baby and hopefully affect later outcome. Although we don't know. This is a study we did we looked at babies who were subjected to a NIDCAP intervention during retinopathy of prematurity eye screening. And what we could find, it was randomized and with a crossover design, but so these are salivary cortisol measures before baseline, then we gave the eye drops before exam, just immediately before exam, 30 minutes after, 60 minutes after, and 4 hours after the eye exam. And these are the ones exposed to NIDCAP, and then the others are exposed to standard care. And what we could see was that there was a slight reduction already before exam, and then as expected, the cortisol levels were rising, and these are salivary cortisol levels, and then they dropped down. And the speed of the reduction here was significantly different from the control, so they recovered sooner in their cortisol replies, but there were no differences in pain responses in these children. I will spend the last couple of minutes just to introduce this paper, which came out last year, and which I think summarizes very well what does individuals' developmental care mean for the parents. And this is a summary. I took all the text here because I think it's important. This paper has been produced to assist clinicians in the development of unit-based clinical practice guidelines and enabling them to benchmark practice recommendations against systematic reviews that explore neurodevelopmental care. The recommendations in this paper are based on the level of quality, relevance, and strength of systematic reviews applied to each. So the baseline is systematic reviews that were evaluated during an evidence level scale from Joanna Briggs Institute. That is a little bit special because it's graded based on feasibility, appropriateness for the NICU care, meaningfulness, and effectiveness. And so this is a slightly different level of evidence and grades, but it's used mainly for nursing care interventions. And I'm just listing here. So A means strong recommendation for certain health management strategies. It is clear that desirable effects outweigh undesirable effects of the strategy. There is evidence of adequate quality supporting its use. There is a benefit or no impact on resource use. Values, preferences, and the patient experience have been taken into account. B, weak recommendation for certain health management strategy, and I'm not reading this. So I will just list what they were looking at in the following slides. First, they looked at parent-infant separation, and you can see the grading over here. Almost all of the reviews and systematic reviews and meta-analysis had very high level of evidence. And this included sensitive care practices, access for the family to 24-hour, 7 days per week, and supporting parents in their skills to observe and to interpret their infant's behavior. I will not go through everything, and I'm happy to share these slides with you. And also I think the publication is open access, but I'm not sure. But I think it's really very, very good. Skin to skin care, again, you can see that they all have this A grade, and it talks about what we already talked about. It can support physiological regulation of temperature and heart rate, improves breast milk supply and breastfeeding, and so on. Again, we come back to this here, feeding, breastfeeding, again, a lot of A's. And what we talked about, nutrition is closely linked to neurodevelopmental outcomes. with breastfeeding identified as the optimal method of infant feeding to reduce risks of infant morbidity and mortality and improve long-term cognitive functioning. This has high level of evidence, and I will not proceed through all these. Next, so looking at the sensory environment, and here there is more like a mix. But what they say, intervention should continue to focus on reducing ambient noise of equipment and general NICU activity. There's a strong degree of evidence for that. Single family rooms are recommended as they can improve outcomes. And also, I think, if you come down here, sound-activated noise meters should be considered in the NICU. But also, I think what's interesting here is that the human voice can assist in reducing infant stress. So we should try to talk to the babies. We know that. And also, this was more surprising to me, reading to infants in the NICU should be encouraged, as it can have positive impact on parenting behaviors and attitudes of the infant's cognitive development. Again, sleep, promote and protect sleep in the babies, and reduce pain and stress, which we already talked about, use pain scale, but also educate parents how to best support their infants. One of the most important things here is to have a well-educated staff, so we can provide individualized care and also support and minimize the infant's stress and support their sleep. And not least, to have a systematic follow-up, so we know what we're doing, but also so we can find babies who have a development that is not optimal, so we can support them. And I would like to this is my next to last slide, just show this slide. I don't know how familiar you are with the Bliss organization in the United Kingdom. It's a parental organization, and they have a lot of documents on their site and on their website. And I think some of them are really very, very good. They have standards. Charter Principle 1, every baby should be treated as an individual and with dignity, respecting their social, developmental, and emotional needs, as well as their medical and surgical needs. This includes respecting the baby and family's right to privacy, time to make attachment, and referring to the baby by name. I don't think you can mention this better than they have done. So I do recommend, if you haven't seen them, read them and see if this is applicable. So with this, I would like to stop, just very briefly summarizing. Neonatal pain and stress have negative effects on brain growth and development, that is for sure. So what can we do? We can reduce pain exposure and stress exposure as much as possible in the NICU, although we know that it's not possible to take away everything, because then we cannot manage the babies, and they may suffer from other conditions if we don't, for example, measure blood tests. But we can use non-pharmacological and pharmacological pain treatment to help the babies, but we don't know really if they help in the long run. What we also know is now that especially the very, very early pain exposure is detrimental for the babies. And what we can do, for example, is to prolong the use of umbilical catheters, so we don't have to make invasive blood test samples. And we also know that developmentally adapted and family-centered care promotes the infant development. With that, I would like to thank you for your attention.